Welcome to Final BDS MADC. Discuss ameloblastoma is an important 7-marker question from the subject of oral medicine and radiology. The introduction, Wallace in 1885 first coined the term adamantinoma and Churchill in 1934 called it ameloblastoma. It is a true neoplasm of enamel organ type tissue which does not undergo differentiation to the point of enamel formation. Robinson defined it as usually unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. Is the etiology. Irritation might be considered as one of the etiological factors as it often occurs in the posterior region of the mandible, which is most susceptible to irritation. Robinson found that one-third of the cases have history of oral infection, extraction of teeth, and injuries to teeth. Trauma also can be a causative factor for ameloblastoma. Dietary deficiency has been considered to be a possible factor. Example, pronounced defect in development of tooth germ as seen in rickets may lead to irregularity in the ameloblastic layer. And injection of polyomaviruses and nitrosoureas have been shown to produce ameloblastoma-like lesion in animals. Next is the pathogenesis. The tumor may be derived from cell rests of dental organ, either remnants of the dental lamina, that is cell rests of series, or remnants of the Hertwig's epithelial root sheath, that is epithelial rests of molasses. Epithelium of odontogenic cyst, particularly the dentagerous cyst, disturbances of the developing enamel organ, and basal cells of the surface epithelium of the jaws. Classification, depending on their structure, they may be solid, cystic, that is unicystic or multicystic, and desmoplastic. And according to the histological pattern, they can be follicular, plexiform, mixed, acanthomatous, granular cell, etc. Clinical features. Ameloblastoma accounts for approx 1% of all tumors and 11% of all odontogenic tumors. It has slight predilection for males and often seen in blacks. Most patients are between 20 and 50 years of age, with mean age of discovery being 40 years. The tumor can occur in young children. Unicystic type of ameloblastoma is more common in the second and third decade, and the extraosseous form is more common in the older age group. It develops in the molar ramus area, approx 3/4 of the cases in the mandible, and also occurs in maxilla and third molar area, followed by maxillary sinus and floor of the nose. The right side of the mandible is affected slightly more as compared to the left side. Neoplasm is frequently preceded by extraction of teeth, cystectomy, and some other traumatic episodes. It begins as a central lesion of the bone, which is slowly destructive but tends to expand bone rather than perforating it. Patient notices a gradually increasing facial asymmetry. Teeth in involved region are displaced and become mobile. Pain and paresthesia may occur if the lesion is pressing upon a nerve or is secondarily infected. In later stages, the lesion may show ovoid and fusiform enlargement that is hard but non-tender. If it is left untreated for many years, the expansion may be extremely disfiguring, fungating, and ulcerative type of growth characteristic of carcinoma can be seen. Is the eggshell crackling. As tumor enlarges, palpation may elicit a hard sensation or crepitus. Surrounding bone may become thin so that fluctuation and eggshell crackling may be elicited. Maxillary ameloblastoma, due to tendency for the former lesion to spread more extensively in the more porous maxillary bone and possibility of the involvement of the cranial base, it may extend into the paranasal air sinuses, orbit, or the nasopharynx. Then mural ameloblastoma. Ameloblastoma may form from the epithelial lining of the dentagerous cyst, and in such cases it is called as mural ameloblastoma. This spread causes expansion of the bone rather than destruction. Ameloblastoma infiltrates cancellous bone, but it is largely confined by the compact bone. It never infiltrates Haversian canal. It infiltrates between the trabeculae of the cancellous bone and hence leaves them intact for some duration. Hence, the actual margins of the lesion are much greater than radiological margin, which accounts for recurrence rate if neglected. As the cortical plates of maxilla are thin, it does not possess an effective barrier to the spread of ameloblastoma into adjacent vital structures. Maxillary lesions are more dangerous than mandibular lesions. The radiographic features, as described by H.M. Worth, four types of appearances are seen. First is the unicystic type. It appears as a unilocular radiolucency resembling a cyst. However, unlike a cyst, it causes a break or discontinuity in the peripheral cortex and may even show trabeculae within the lumen. Then is the spider variety. This is the most common appearance where the lesion is seen as a large radiolucent area with scalloped borders. From the center of the lumen, coarse strands of trabeculae radiate peripherally, giving rise to an appearance like gross caricature of a spider. Then is the multilocular radiolucency. Ameloblastomas may be seen as multilocular radiolucencies having a soap bubble appearance or bunch of grape type of appearance. Then is the solid ameloblastoma. It is one which has not undergone cystic degeneration. Hence, multiple small radiolucencies are seen surrounded by hexagonal or polygonal thick-walled bony cortices, giving rise to a honeycomb appearance. The internal structure of ameloblastoma varies from totally radiolucent to different internal septal patterns. The septa are derived from the bone trapped within the tumor, which are remodeled into coarse and curved shape by the cystic components. The resulting multilocular pattern has larger locules of variable shape in the posterior region of mandible, giving rise to soap bubble appearance. And if the locules are smaller with polygonal thick walls, it is termed honeycomb pattern. In desmoplastic ameloblastoma, the lumen shows very irregular sclerotic bone resembling a bone dysplasia or bone forming tumor and also has a lucent area within. Peripherally, the ameloblastoma causes thinning of cortical plate appearing as an eggshell on occlusal view. Displacement and resorption of teeth is commonly seen on the radiographs. Additional imaging. CT scan helps in studying the lesion in three dimensions. Exact extent and content of the lesion and its effect on adjacent anatomical landmarks can also be appreciated. CT also reveals the perforation of the cortical margins and soft tissue spread of the tumor, and hence it is indispensable in treatment planning. MDCT is preferred to CBCT as it displays the soft tissues more clearly. MRI can provide superior images of extensive invasion of the tumor into soft tissues, and hence it is preferred to CT scan. If it occurs in the mandible, it may spread to the inferior border, giving rise to fracture. They also have a high rate of recurrence. Next are the differentiating points between a cyst and a benign tumor. The radiolucency of a cyst is more due to its fluid content, and the radiolucency of a tumor is less due to its tissue content. The borders are smooth, round, and continuous and corticated in cyst, and the borders of the lesion are scalloped in a benign tumor. Trabeculae are usually absent within the cyst, but trabeculae may be present within the tumor. Septa are absent in a cyst but present in a benign tumor. Cysts cause only buccal expansion except in primordial cyst, which may cause lingual expansion as well. And in a benign tumor, tumors cause buccal and lingual expansion. Root resorption and displacement is less common in a cyst and it is more marked in a benign tumor. Fluid may be obtained on aspiration of a cyst and no fluid is yielded on aspiration of a benign tumor. Eggshell crackling may be present with large cyst, but no eggshell crackling is noted in a benign tumor. Differential diagnosis also includes giant cell granuloma. It may resemble ameloblastoma, but it is anterior to the first molars, and it is common in younger patients, and they have delicate wispy stria. Then odontogenic myxoma also represents ameloblastoma as they have a multilocular appearance, but the septa are straight and linear, meeting at right angles, giving a tennis racket appearance. And myxomas are also not as expansile as ameloblastoma. Then third one is ossifying fibromas. They have septa which are wide, granular and ill-defined. Point is the treatment. Extensive surgical treatment, that is surgical resection, is essential to prevent recurrence. Maxillary ameloblastomas are treated more aggressively as they have a tendency to invade adjacent vital structures. Inoperable tumors involving posterior maxilla may be subjected to radiotherapy. That's it. Thank you for watching. If you appreciate this video, do hit the like button, share it with your friends, and please subscribe to my YouTube channel. Hit the bell icon for more regular updates.